Now we're going to look at specific health policies within states. Again, they're this sort of incubator of ideas and why things did or didn't happen, and we're going to look at three different ones. First of all, Massachusetts, the Affordable Care Act, as we talked about in the last class, that's where it came from. It passed it, it got coverage of lots and lots of people, so it was very successful. This was a Republican-oriented bill. One of the things that you need to think in mind is sort of what were the inputs that got us the outputs, right? So what was happening was there was a sense of urgency created because you needed to renew the state's health care waiver, and you were going to lose lots of federal money if you didn't do that. They had very strong reform previously that said we want to have a safety net system in place with lots of Medicaid coverage, and they wanted to have some kind of care that people who are uninsured could still receive care. So those sort of ideas were already there. They also, in addition, had a relatively high level of employers providing health care to people, right? So then there was a very small amount of people who were uninsured, right? Less than 10%, compared with the nation at large, which is 16 to 20% at that point. So they were sort of very small. They had underlying ideas already in place. They had a small population they were trying to address the issues with. The third was that they had a lot of resources and uncompensated care pools that they could help finance the change. So the state also had a really progressive relationship with insurance companies and regulators prior to the reform. So they really wanted to work with them. They'd already had an established relationship. And the interest groups were all ready to work together to make sure that the state moved forward. Again, they had this previously really good working relationship, and these reforms were very broad-based. The people who sold these reforms, the governor, all the state legislators, very much were on board with what the interests were of all the players. They knew what the insurance companies wanted. They knew what the state's policies were. They knew who they wanted to cover, how they wanted to target. They also knew ways they could do it, ways they couldn't. They also were very good at defining who was affordable, who wasn't, what they could get. Okay, so they had stuff in place going in. They could innovate because they had a very small amount of people they had to cover. A lot of other people were not even part of the mix, so they could very much experiment. They had a lot of money in case this went awry. They also had a very big culture in the state of wanting to make sure that people got care. Let's contrast this with somewhere like Texas, where they don't believe in taxing and spending. They don't actually have a state income tax. They have constraints. They also don't really meet that much, so their legislator has a very few days. So that sort of working relationship with other legislators, with interest groups, with state regulators of insurance companies is going to be minimal because there's not a lot of days to interact at all. Also, they don't have a lot of additional resources because they don't tax and spend, and they're very much a state that figures out that they do not want to necessarily spend a rainy day fund to spend on people with health care. They want to spend it on other things that they think will help their government. Hence, they don't have a great system in place. There's not great health policy in that state, despite being a huge state. They also don't have a lot of research on how to improve their Medicaid system. They don't have the political will or wanting to. And during the times when they have changed, they've also seen a change in people voting out Democrats and voting in Republicans who are not, by their very nature, open and want a lot of change, and or they're not elected by the people who are not covered. Okay, so again, constraints, and it's not going to happen. Now let's go to somewhere like Oregon, another instigator of change. They very much wanted to change and improve their Medicaid system. So what they sort of did was they expanded it, but they expanded it because the state has this culture of wanting to make sure everyone has a minimal standard of care. They expanded it. That's great, but they limited what services people could get. So it's not the same as what you could get in other states' Medicaid coverage. That means that you cannot get transplants and stuff like that, which you couldn't get here. So they excluded a lot of stuff that you can get. They created a minimum level of care. They expanded who could get it and who couldn't. They reduced the medical package. They excluded dental and hearing and visual care. They reduced a lot of other outpatient mental health care and, drug and alcohol treatment programs. So they excluded a whole lot of stuff that is standard everywhere else for Medicaid people. Then they had bipartisan legislator to work together to come up with a plan. They also made sure that everybody in the state was on board with this, that everybody thought this was a good plan to have in place, that these were good services, minimal level of services to do, so that people wouldn't get voted out if they passed something because there was not a big public consensus. So they were sort of thinking ahead, right? But what they put in place was you have expanded healthcare, but you have rationing, and everything else after that you have to pay out of pocket. That's very controversial. It's a minimum standard of care, but it may not be the one that you could get in other states. It's very much, people are still getting access to health care. They do save money. They haven't had as big an expansion in the cost of health care for Medicaid patients. So they're getting there. They're producing what they want. The problem is that most people would not think that was an acceptable standard of care, but they tied them together, in part because they could, because of their political culture. So these are 3 different states that did very innovative or not innovative coverage and care. And in part, it's culture. It's how the political actors engage and interact with each other. It's what interest groups have the most voice. And it's also, is there money available? So who pays, who's involved, what's the culture, are very big questions you need to ask anytime you look at a policy change or anytime you want to instigate it at a state level. But we literally have 50 plus different types of coverage and different implementations of things like Medicaid, in part because it's a federalist system. You can innovate, but it also means we do not have a uniform standard of care. In other countries, in Canada, if you're in a different region, you still get the same level of care. You may have to wait a little bit longer to get certain things, but everybody gets a minimum standard no matter where they live. In America, for people who especially are poor, it is very much dependent on where you're born and where you live as to what kind of care you get and health care you get from the government. It's also dependent on what kind of things and policy changes that you will be able to see, what the relationship is with insurance regulators for those people who have third-party payment, and what kind of policies you will or won't get. So where you live does still matter with policy. And that is one of the reasons why people wanted the federal government to change, but it's also one of the reasons the federal government took something that worked in Massachusetts. It was very conservative and looked like it worked, and then we're willing to adapt it at the national level. So they're laboratories. It does mean everybody gets a different output, different chemical mix, but it's also a way to say this works here, and you as a policy person can say let's adapt it and change policies at a federal level, which could supersede those local, state level changes.